let's go ahead. You should see, let's see. All right, you should see it all on the screen right now.
Yes.
Good. All right, we'll get started. Like I said, I'm really excited about this talk. I was fun to, this is one of those where I got to delve into the history of it and get into the pharmacy of it, but the clinical chemistry of it. I haven't mentioned it. If I didn't do pharmacy, I probably would have done medicinal chemistry or something like that. And the more I got into this talk, the more I realized that so much of it is the chemistry of it makes a huge difference in terms of explaining the differences between types of MAOIs, individual, just looking at the molecular structure, even explaining questions about side effects. And so even if that's not your thing, I think it's kind of cool because it helps me to remember the differences as far as what the side effects are by looking at the structure and classification of them. So I try to put together a couple of objectives here, again, explaining the differences based upon their structure and activity, the importance of the tyramine content, select an appropriate MAOI based on patient-specific factors. And I will admit, I have probably only had 3 patients on an MAOI in 12 years. One guy inpatient in that was on phenelzine, one outpatient that was on meclobamide, and that's one I'll talk about as a very weird one. And I think maybe had somebody on tranylcypromine, and there might have been a couple just inpatient in Buffalo when I was starting out that just, it was in there kind of as a cursory thing, but not that I had much interaction with it. For you all, I guess right now, who here has had experience with MAOIs? I mean, as far as in their clinic, managing them or switching to one from one. Be curious to know your all's experience thus far.
I've had one patient on one and out actually inpatient. It worked really well for her, but then she would be discharged and her outpatient person would take her off of it and she quickly decompensate and then back up in the hospital. But that was my experience.
Anyone else? And that reminds me because that's the one thing that the more I think about MAOIs, and again, as I didn't have a lot of experience, but that's why I deferred a lot to the literature. But we have another medication, clozapine, which has this tremendous benefit, but then also has people are very wary of using it due to some well-documented side effects and concerns that, in modern days maybe aren't as big of a deal, but there is that hesitancy. So the more I read about it, the more I kind of thought about it against clozapine. Anyone else?
Yeah, I had a patient on an inpatient setting that we started on a selegiline patch and it seemed to work well for him, but I have no idea and was lost to follow up for me at least. So yeah, that's my only experience though.
Okay, cool. And yeah, and we'll talk about that one as well. Doesn't get thought of, it's a little bit different, but that can be another option for somebody who wants to use one and is very concerned about kind of the old school, the big 3 or 4 that were first out. Anyone else? So we have one Selegilin, one. Sorry, Dr. Good. Which one was it? You said phenelzine.
It was phenelzine.
Okay, so one phenelzine, one Selegilin. Anyone else?
I've seen a few patients just kind of briefly, like while they're in the hospital on them. And my experience is like discontinuing them, not starting them. I don't think I've ever started anybody on an MAOI, but not much follow up after that. So I honestly don't remember much about it.
Okay, well, we'll hopefully again go into it. The one disclaimer, as I said, is because I admittedly don't have a wealth of it. A lot of it, for you'll see as a reference, is a guy named. Has anyone heard of P.K. Gilman out of Australia? Or this, I think he has his site's like Neotropical Psychiatry or something like that. It has a really cool name.
Dr. Stahl at APA talked about AMAOIs in his talk this year or last year, and he mentioned him and his work and his website. Is he the one that has the email where you can just email them and they'll like run everything through and tell you what to do, how to manage the MAOI?
Yeah, he has some
Yeah.
he has some cool stuff on his website. Yeah, he and a couple other people, like he's really TCAs and MAOIs are his thing, and he's one that he's big on the molecular structure and kind of has a little bit of the Rage Against the Machine that like David Healy has over in the UK, but seems a little less narcissistic, with all due respect, than some of the other ones who kind of just seemed like to just be cranky for the sake of being cranky. But Dr. Gilman is very much about, we need to go back and be using these medications, but he doesn't just complain about it. He has these clinics and these services where he really works hard to help people use those medications. And so his work has been invaluable, and that's why you'll see it all throughout here. So without any further delay, again, just really briefly, there is a DSM-5 criteria for MDD. This is what it looks like, although this is not the revised, but this is the 13. So here it is. All just to say that, don't forget about something like atypical depression, which became, maybe one of the big ways to consider using an MAOI was, okay, if somebody has atypical depression, that can be a time to use it. But they will even argue, and actually one of the reasons why it's a good time to talk about it is in 2013, Gilman and a bunch of others published 2 big papers, one of them a consensus paper on how to use them, and another paper about how to manage the dietary restrictions. So it's a good time to talk about this stuff, and they believe well beyond using it in atypical depression, but that is something, an area where it can be a niche for this medication. Although initially it was, that's, the big medication, the only one you could use was MAOIs. Well, there's been a couple studies of different ones, I think even some SSRIs that have been used in it, but for a while that was the big hallmark, was this is where you use an MAOI. But a few other pieces of it, or at least again at the time of DSM-5, again, just to be thinking about, what are our neurotransmitter targets? And we have a somewhat outdated model, but the idea about the monoamine hypothesis, and then we've expanded it out. So we have all of these different targets, not just the monoamines, but other receptors, inhibitory and excitatory neurotransmitters. Glutamate, that's been the hot one for a number of years because of, it's ketamine or topiramate or lamotrigine, a number of medications working on this system. And then really just to build it up as the idea that, we have a number of targets, but really, you can see the one in that middle, that kind of the Venn diagram, where you will get a whole lot of benefit across the board on all of these neurotransmitters. The increasing norepinephrine availability, dopamine, serotonin is going to be your MAOI there. And I think there was another drug, someone said high dose venlafaxine, or there's another kind of combo venlafaxine product that may also target the reuptake inhibitor for all 3. But really, MAOIs, that may be a lot of the benefit, is robust effects on all 3 of these neurotransmitters. But first, I want to get into the history of it, which is really interesting. So when they first, the early research was Nathan Klein, or at Rockland State Hospital in Orangeburg, New York. And up there, they have the Nathan Klein Institute for Psychiatric Research. And I had briefly heard about that when I was up in Buffalo. I'd heard the name, heard about research, and didn't really think much of it. But then going back, and where did they come from? It was really from him. And I think I talk about it on a later slide. But the interesting thing is, do you guys know where they first got the MAOIs from, or what they were made from? And the answer is rocket fuel. There was a lot of rocket fuel that was available after World War II, a lot of it coming out of Germany. And so they were able to use that hydrazine specifically as one of the agents. It was a very explosive, not the best one to use for rockets, but hydrazine, not hydralazine, although it kind of fits into structurally similar. Hydrazine, very volatile, used in rocket fuel. They found other ones that won't blow things up as much. And I would have had pictures of the rockets on here, but most of them had Nazi symbols on the picture. So I try to keep Nazis out of my slides. So no pictures about it, just a picture of some hospital beds. But the first one that really got used was they had the hydrazine there. There was some banding about monoamines, but then iproniazid came out and was used in the 40s and 50s to treat tuberculosis. And as with some of these serendipitous effects, they noted, hey, this seems to really help on a mood component, not just helping with tuberculosis. And so really the first use for depression was in 57. Again, that was from Dr. Klein. he had said, 5 months of treatment, a minimum of 70% improvement in these papers. And it's kind of cool, but a couple of these papers, I was able to find the old papers. There's a few journals that have archived online all the way back to the 1800s. And so you can read some of these early case reports. And then if you're interested in that first book by Shorter, Troubled History, Mood Disorders, and Psychiatry, it sounds like a negative book, but they did a really good job, at least the chapter I read about MAOIs, in talking about how it came about. And, there was this early interest, you had MAOIs, you had this monoamine theory, and then people started looking into this iproniazid and getting this idea that it did something with these monoamines. And so it was on the market for about 4 years. A lot of benefit in a number of patients. And some of the studies, I think I'll talk about them a little bit later, but they're really in, not everyone, but there was a very large sample that did incredibly well on this medication. Again, like clozapine, and that's what I'll compare to. It wasn't, this isn't the medicine for everyone, but for those who did well on it, those who tolerated it, this was a life-changing medication. But unfortunately, hepatotoxicity was withdrawn from the market, and that's something that will come up with the MAOIs in general. Is it's not fully known how it happens, at least not that I saw. If anyone has any information, they can let me know, but they're still trying to figure out. But they do have, in rare cases, some significant hepatotoxicity, which it's not the first. That's where nifazodone was a medication that can on and off the market, and a lot of concern with hepatotoxicity. As I mentioned, historically, and again, as always, if you guys want to jump in, questions, comments, thoughts, feel free to make this as interactive as possible. As I mentioned, historically, they've considered a strong go-to option for atypical depression. A few newer studies did come out saying, oh, some of the SSRIs, it might have been citalopram, had some benefit for atypical depression. And I think that's maybe another reason, okay, if we have these newer medicines, maybe they're safer, then you're moving towards those. And so where MAOI is at now, maybe second or third line for treatment of MDD, PTSD, anxiety disorders. I know in the 2007, 2008 PTSD guidelines, I think phenelzine was actually on there. I think that was one of those that got kind of moved around in the most recent one, but that was on there as a third line option. Side effect profile, not much different than the SSRIs. Again, as a general rule, as we'll see, individual medications, individual molecules do have some different side effect profiles. But overall, you still have weight gain, sexual dysfunction, sedation. Oh, I guess I already have it on there. Particularly with isocarboxazid and phenelzine, not as much with tranylcypromine. And again, that will go back to some of the structural piece of it. And then hypotension, more unique to MAOIs. We talk about, you think, oh my goodness, tyramine hypertensive crisis, but they tend to be more of a hypotensive medication. Which actually, and the easy way to think about that is, you all familiar with hydralazine, used generally for someone in hypertensive urgency, or just an add-on when you've tried every other basic blood pressure medicine. But I was thinking about the name, wait, hydrazine, hydralazine, phenelzine, and hydralazine is structurally similar. So that same effect of hydralazine affects blood pressure and has a blood pressure lowering effect. So do monoamine oxidase inhibitors that are all structurally fairly similar to it. And in fact, I believe it's carbidopa is also a monoamine oxidase inhibitor. And we know about the role of Parkinsonian medications and hypotension. So again, the way of remembering some of these side effects is thinking about the other medications that you do know. So there's a number of different ways to classify them. And I think this is important. It really helped me, because the more you understand these differences, the more it will help if you are going to use one in clinical practice to determine, what's available and which one maybe has a better profile for the individual patient. So a couple ways to look at it: monoamine oxidase A versus B inhibition, or is it both? Is it one? Is it reversible? Is it irreversible? And again, in the US, that one's probably not going to matter as much, but maybe one day. Is it selective? Is it non-selective? And then is it a hydrazine versus non-hydrazine? So one of them you're probably aware of is the idea that, yes, we have the monoamine A, and I was taught, A for 8 something and B for brain. That's probably a little bit too cute and trite and not necessarily accurate because both of them are in the brain. But yes, A tends to be the one within the gut. And so a non-specific or a drug that targets monoamine oxidase A is going to have effects in the gut, and then is where your dietary considerations are important, but it also affects what it metabolizes. So you can see the gut is the chief monoamine in the gut is A, but it's also in the locus ceruleus, and so involved in some noradrenergic projections, also the substantia nigra from a dopamine standpoint. It breaks down any of the hydroxylated amines, so serotonin, norepinephrine, epinephrine, but then will, when it's available in high enough concentration, break down dopamine, tyramine, and tryptamine. And so tyramine being, again, a big one as far as side effects go. And then monoamine oxidase B, B for brain. Again, this is the chief one in the brain, although they both are there. This one preferentially breaks down the non-hydroxylated amines, so phenylethylamine, benzylamine, and we'll talk actually at the end. I didn't add on as something that Dr. Gilman talked about, and I've been interested, is a new class of medication called trace amines as a target beyond these major monoamines, these trace ones. So we'll get into that a little bit at the end, but I'm getting ahead of myself. So that one also breaks down dopamine, tyramine, tryptamine. This is a slide I pulled from a talk I did a couple of years ago. And you can see here that there's more MAOB in areas in the brain. So even though they're both in the substantia nigra, you can see overall, I believe B is going to be the one on the darker on top. So it's much more in these brain areas, although you'll still see spikes. Make sure I'm pointing on the right screen. So you'll still see spikes here in maybe the medial temporal lobe, and then a few other areas here where you'll see monoamine A, but predominantly it's going to be B that is there in the greater concentration. Again, the enzyme being there. So the other way to look about it is going to be reversible versus irreversible. And this is one not as much of a point in the US because we really only have some of the irreversible ones. But what happens is the irreversible monoamine forms covalent bonds. So instead of your ionic bonds that associate, this forms these very strong covalent bonds, and not even dialysis can destroy these. So when the drug binds to the monoamine oxidase and inhibits it, it completely binds to it, gets rid of it, so that monoamine oxidase is not able to do its job. And so just like we talk about something like aspirin binding to the platelet for the life of the platelet, that is what we're getting here. So it takes time. You have to create new protein, new enzymes, even to get your monoamine oxidase to work again. It has a half-life of 9 hours in the rat brain, so it's going to take time. And as you can see, a therapeutic dose will inhibit up to 90% of the enzyme. It's going to take days to weeks to regenerate. And even if that happens, again, if the drug's still available, the drug's just waiting there, and you make a new enzyme, drug binds to it. So irreversibly until you stop it. And again, even then, you're not going to see any monoamine oxidase enzyme until the drug is gone, it's washed out, and you're making new proteins. Now, reversible ones are different. This is more of a competitive inhibition where it's about not covalently bonding, but just getting in the way. Excuse me. If you can visualize like a crystalline structure, and so you have the monoamine oxidase there, and then you have the drug, and the drug just gets in the way. And it makes sense that in the next couple of slides, when we look at the structure of the reversible ones, the structure is going to be much bulkier because that's what they're doing. They're the steric hindrance, getting in the way with a couple of extra rings, and because of that, the other substances that are going to be broken down by monoamine oxidase can't get in the way. And once the concentration drops below a threshold, it's generally 80%, the effect is lost. And so because of that, the drug has to be given twice a day, because if you give it once a day, and the drug is competing, but then as drug breaks down, it leaves the receptor, and then now monoamine oxidase is available later on that day. And so they're much quicker to get off. And so this is one, and you may already be thinking, why don't we have these available in the US? And I honestly don't fully know, but they are not. They're available in other countries, but in the US, we only have irreversible MAOIs, not the reversible ones. But that is the nice thing about them is, again, almost comparing aspirin to, Lovenox or to even to Eliquis, or one of the newer ones, is the idea that you can kind of set a watch to it and know that we're going to give it. And if we have any issues, we can stop it. And now the body is able to go back to, so if you have a side effect, you can just stop the medication, get the ability to regenerate the monoamine oxidase, and go on with whatever else you wanted to do. Don't have that with the irreversible ones. Other way to look at it is the selectivity of monoamine A versus monoamine B. Some drugs block A, some drugs block B, others don't care, and they'll block them both. And here's where the structure matters. So on the left-hand side right now, I have the non-hydrazines. And so you can see here, we have meclobamide, which I mentioned. This is the one not available in the US. I had the intriguing option of, I had a consult when I was just a year or two out of residency at the VA, and the provider was, hey, I'm trying to put in a non-forming. This patient says he was on meclobamide and he was getting it, and looked into it, like, well, that's not available. Where were you getting it? Turns out he was getting, I can't remember, somehow he was able to mail order it from Canada. I don't know if there was a physician involved or how long ago they were involved, but he was getting this from Canada and said it was wonderful for his depression, but he was having trouble getting it. And they were consulting us about what to do and how to find another option. And I think we had looked into Seledulin, but I believe the provider just ended up switching him to something like an SNRI. I feel like it was venlafaxine, but I can't remember. But that is that reversible inhibitor of monoamine oxidase A, or AREMA. But as you can see, structurally, they all have this ring structure right. Oh, sorry, I keep pointing to the wrong screen. Sorry. They all have this ring structure right here, but you can see outside the hallmark is you kind of have 1 or 2 carbons and then a nitrogen bond. And that is kind of the fingerprint of an MAOI. But then all this, the side chain is a lot bulkier with meclobamide, which I believe is what allows it to be a competitive inhibitor of monoamine oxidase. And then the others here, you see the structure is a bit different, and we'll talk about what this means, but having a ring in this other place here, such as in tranylcypromine and rasagiline, they both have a ring attached to the nitrogen atom, which actually affects its metabolism in a pretty important way that Seledulin lacks. And so once again, the structure really does matter. So over here, you can see the hydrazine bond. So hydrogen is a pretty simple molecule. And I can imagine from again, I'm not a medicinal chemist, but if you break that nitrogen bond there, and because of the fact that nitrogen likes having a couple of extra, the little unpaired electrons, so you could probably create a lot of energy by cleaving some of those bonds there. So I can see that, but that is the structure of hydrazine. So not surprisingly, the hydrazine MAOIs and other molecules have that nitrogen-nitrogen bond that we lack in those on the left. And so that's one of the hallmarks of them. So a lot of these all act the same way. And we will try to tease them out. So when we talk about the big 3 non-selective A, B irreversible ones, we talk about phenelzine, isocarboxazid, and tranylcypromine. So you can see 2 of them are hydrazines, and then the one odd man out is going to be tranylcypromine, and that'll make a difference. And then isocarboxazid, which is used occasionally, iproniazid I mentioned, and these are very similar to isoniazid, which is used for tuberculosis. I don't know if it's still used. I haven't worked at TB clinic since pharmacy school. The other one I threw on here is carbidopa, just so you can see that as well. So carbidopa even itself has the nitrogen-nitrogen bond, so used in Parkinson's, but some of the same characteristics apply to it as well. So I mentioned hydrazine as rocket fuel, and it was Hoffman and LaRoche in the 40s and 50s used it to make iproniazid and isoniazid. And as I mentioned, we noticed that, okay, this seems to have an effect on mood as well as the effects it's having on tuberculosis. And that was kind of that serendipity there. And it was specifically the Messerschmitt comet was one of those planes. And again, that was Germans used it. Those pesky, well, Nazi images, so no paraphernalia on these slides. And I mentioned, oh, sorry, I didn't mention it, but going back to the structure, since we have it here, an important thing to note is, have you all heard about any of these that convert to amphetamines? Are you all aware of any conversion of MAOIs into amphetamines? And if so, which one? Some people say tranosipramine will. P.K. Gilman says that's, as far as he can tell, that's not true because it doesn't have a lot of the hallmarks of hypertension, tachycardia, and things like that you would see. But selegiline does. And it's interesting because if you notice, again, I like the chemistry of it because it makes sense, but each one of these, you see the ring structure here with rasagiline, and then we see a ring structure right there next to the nitrogen selegiline, and then you kind of have the ring here, and then you have this carbonyl bond here with meclobamide. But all that to say that that bond there, because there's nothing here with selegiline, you can actually have something come in and break off part of it, and you end up turning that into an amphetamine. So selegiline, because of its structure, can convert it into an amphetamine, which if you want something that has some amphetamine-like effects, that is going to be possible with selegiline, and it appears unique to that one because it's only something with these non-hydrazines, and again, only the one that has the structure available of that bond now, that kind of carbon bond next to the nitrogen. So again, even if you don't like the chemistry of it, I think it really is helpful to knowing what these different molecules do. And so I forgot I circled them all. All right. So just to summarize the differences, go left to right. So we have one available selective reversible monoamine oxidase inhibitor. Again, not available in the US unless you want to import it, which the FDA would say no, but this is something, I would be very curious about, why that's not available. And, is there a role for that? Is there, when we start, when neuro drug design and neuro drug discovery is kind of petering out in some ways, is there a role for something like that? I think there might be, but we don't have it right now. So the selective ones, those are selective for B of the brain. What that means is you should be able to avoid some of the interactions with tyramine in food because they're not there. Again, A is primary in the stomach, but a little bit in the brain. B, it's essentially only in the brain, not within the gut. So don't have to worry about the dietary restrictions so long as the dose is appropriate. And so selegiline 6 to 10 milligrams is a dose where it's selective. Excuse me, drinking coffee too fast. But as with many medications or chemical reactions, the more you increase the amount of what you're adding into the formula, the more it's going to create other products. Or in this case, the more available it is, it's going to saturate the monoamine B receptors or monoamine B enzyme, and then it will start moving to A as well. And so you have to be careful that when you get above the 10 milligrams of selegiline. Rasagiline, regardless of the dose, that one is selective. And then you can see the AB non-selective. So once again, these are the ones that are going to have the dietary restrictions. They're all irreversible. Selegiline higher than 6 to 10 milligrams. Some resources said 6 was the cap, some said 10. So definitely above 10. So there's a little gray area around 10, where it may be okay, but you want to be careful. And then the rest are all irreversible and non-selective. Any questions so far? Any thoughts, comments about this stuff? Again, hopefully you're not bored to death of the formulas. All right, well, I'll keep moving on. Again, there's a boat shipping some meclobamide. So why does it matter? All right. What do you want to know about tyramine?
I feel like we always think about aged cheeses and wines and all the foods that we like to eat.
Yes. And that's what I was telling Dr. Good as I prepared. As I was reading so much, I feel like I can be an artisan cheese manufacturer now because it's been fun reading about it. But yeah, there's a lot more to it than that. And I tried to expand my mind. Again, there's The references on the next, not on this page, but the references on the next couple of pages, wonderful. That if you want to know everything there is about the cheese making process from a psychiatry perspective, Dr. Gilman has you covered, and it's really cool to read it. I probably read way too, again, more than was necessary, and I'm just going to summarize some stuff for you guys, but it was really neat. And as somebody who thinks beer making is really cool, I'm like, okay, it's educational. It's not alcohol. It's not alcoholism. It's just research. So, all right. So yeah, what it is, pressor response, and specifically, the tachycardia being the big, or sorry, the hypertension, not the tachycardia being the big one, but foods high in tyramine. The other thing is it's not always just tyramine, but Dr. Gilman talks about histamine and possibly dopamine, tryptophan, other amino acids that are also involved in some of this pressor response. And so he goes into also talking about foods that are high in histamine and that may contribute. I left that just for the purposes of sticking to what I know a little bit more, as well as to make it a little bit less complex. I try to avoid talking about histamine and tryptophan, but there are other foods, and some patients, should you prescribe an MAOI, some patients you may also want to look at foods and anything else they consume that contains other amino acids, tryptophan, histamine too, but I'm really going to focus on tyramine. And what happens? 30 millimeter mercury increase in systolic blood pressure. Generally not, and in fact, some people can talk like a bradycardia, but it seems like it's generally not manifested as tachycardia, or at least not always, and not as much on the diastolic blood pressure either. Just this really big, that the cardiac contractility increases, but not necessarily the heart rate. So you get an increased force of contraction, and you feel the pounding in your chest, but not necessarily the rate going up, which may be important in trying to figure out what's going on. But it's that big increase in blood pressure that becomes the concern, and then the fact that happens down the road with it. And so the big one is hemorrhage, and that was what happened in a few of the very extreme cases where it actually caused somebody to have a cerebral hemorrhage, and that was some of the fatalities. I said withdrawn the market in 1964. Numerous cases of hypertension. 38. I think it's supposed to be CVD. I think something cut off. Cerebral vascular disease, cardiovascular disease, and 21 deaths. So that was the big piece of it. And again, as with other medications, initial, and then it gets pulled off and really not used as much. But changes has occurred there. There's been an evolution as far as food making, and that's what Dr. Gilman argues. Food making has evolved. The medical system has changed. Purity of things better. So can we do this safer? We might be able to, but yeah, they did come back on the market with those dietary restrictions in place, and it was generally thought of as a restriction. Can't do these things. That has changed more to a limit these things, just to keep people from being afraid of essentially eating, but to try to be careful of what they eat and how much. So a little bit of it, foods containing tyrosine get metabolized to tyramine by decarboxylation by the microbes. And so I thought that was cool because it's the microbes. So anything that deliberately uses microbes to age something. So a nasty cheese or, a beer, but also failure to maintain sterile conditions. And so that's the other piece of it, is it's not always deliberate, but if you have meat that's not at the right temperature, or, you're, I don't know, the food that's deliberately, or, kimchi, things like that in theory, or, yeah, you just leaving food out, it gets nasty, and then something happens. Now it produces, the bacteria turn the tyrosine to tyramine. And you can see here again where L-DOPA is on that pathway too, which is kind of interesting. So again, I thought about rescue rangers, but what are we looking for here? So the main thing is symptoms occurring within 30 to 60 minutes of ingestion of tyramine-rich foods, pounding heartbeat, increased blood pressure, headache, chest tightness. So what you do here, and again, there's some good guidance about what to do, and being careful in a guideline to say, oh, here's how you should manage it.
Can I have your attention, please? All units, the Recovery Center will open at 1 p.m. Please make sure to have your blue band ready to go. Thank you.
All right, the Recovery Center is open. Yeah, so what are you trying to do is bring the blood pressure down, but not be careful to overreact, because there's anything you can overreact and cause other problems. So what does he say for the psychiatrist who gets called about this? He says, again, I am not an emergency doctor, but one thing he said to consider is you probably want to be careful about treating the blood pressure yourself, because I would certainly, am I qualified, to treat, to figure out how to treat this acute cardiovascular condition, have them assess themselves to make sure they're not having a hemorrhage. So get the person seen critical care emergency department. Now, he did say a benzodiazepine, because a lot of it with that surge of, neurotransmitters, talks about kind of curbing anxiety and distress, which may help with the blood pressure too. And so he says, a benzodiazepine can be helpful. He said that would be the only role of a psychiatrist would be if you can get a benzodiazepine in the person to kind of calm them down, maybe slow things down, decrease the anxiety from making it worse, and then get them seen urgently for further management, and to make sure that there's not any end organ, because we're really talking about, end organ damage, hemorrhage, things like that. So, and again, if I didn't mention it, he says, the systolic over 180, diastolic over 120, that's the point at which you're going to need to really, if the blood pressure has gone up a little bit, he argues you may not need to do anything, because the human body can't handle high blood pressures. If anyone's checked their heart rate or their blood pressure when you're going on a run, or even just different times of the day, we have a rhythm to it, and we can handle, our bodies can handle fluctuations in blood pressure. But it's when it's that really high that, we're talking end organ damage. So that's where it becomes a big issue. But not every bit of blood pressure increase necessarily needs that kind of emergent treatment. Yes, it's a scary place to be. I've not had that phone call, and I can only imagine getting that phone call about the potential tyramine crisis, and yeah, that would be very scary. So I think we'll probably stop maybe on this slide, or maybe the next one, and then likely go back over them, because there's a lot of dialogue here. But the big thing to figure out is, so suppressor response is the 30 millimeter mercury increase in blood pressure. How big of an issue is that? And so you can kind of see here, studies have been tricky, because what they were doing when they did the studies is they would give somebody a capsule of tyramine, and then they would check how much of a blood pressure increase there was. Or they would see how much tyramine it takes to get the blood pressure up to a certain point. And the problem with that is it was capsules and fasting. And what they found, a couple things, is that food itself can actually affect it, that there's other substances in food, other amino acids that can lower blood pressure. And so when you're giving someone a capsule of tyramine, none of that is in there moderating it. So it's not quite the same that if you can see here, 437, if they're not on a medication, 437 milligrams of tyramine cause the blood pressure to go up. That's a lot. Sledging 20 milligrams, 96 milligrams of tyramine to go up 30 points blood pressure. 33 if it's phenelzine, 60, 16 milligrams if it's tranylcypromine. So every one of those amounts of food, so it only takes 16 milligrams of tyramine to raise the blood pressure 30 millimeters mercury if you're on tranylcypromine. If you're not on meds at all, it would take 437 milligrams of pure tyramine. So that's one way to look at it and to say, oh my goodness, you can only have 16 milligrams tyramine per meal if you're on tranylcypromine. As I said, the problem is that's pure. Getting it with a meal will mitigate it, that it really may take more tyramine if you're having it with a meal, just because of the foods in the meal, as well as fasting versus fed state. And he even argues later on that you can really triple that number in a lot of cases if they're eating it with a meal. That this is probably a very extreme end kind of scenario, because yeah, we're also not saying here's a tyramine capsule. All right, I will talk about, I think next time, in the interest of time, I'll probably wait here, because there's a lot of good stuff on the next slide, but I think it'll take time to go through it. So it's all right, I'll stop here if there's a question or two, and then we'll probably come back to this slide and the next slide next time, and then go on from there. Any questions, thoughts? Hopefully, as I said, hopefully this is somewhat exciting. I'm excited about it, but hopefully someone else is.
Yeah, this has been super helpful. Does anyone have any questions before we conclude?
Has anyone had this come up? Dr. Summers, I think you were the one that had the most case. Have you ever had that? Has anyone gotten that call? Or I think they're in a tyramine or hypertensive crisis? Or anyone who's attendings have shared that? Because I said that. I said I can talk all the time about, oh, you know, tell them it's fine. It's really not. When it actually occurs, I'm sure it's different.
Dr. Shuman, I'll send you the video. God, my voice is awful. I'll send you the video that Dr. Stahl did at APA. He did like a YMCA parody with MAOIs. It's pretty goofy, but it's like kind of funny too. So I'll send it your way.
Cool. And I feel bad having you talk because every time it sounds like it's just this painful thing, like it, you know, just rubbing sandpaper across some sort of mucosal tissue.
It's actually not. I think I might have bronchitis as well, honestly, because I don't feel bad and I'm not stuffed up. But anyway, I'll stop talking about my health issues. But yeah, thank you so much for your time and effort. As always, this was fantastic. And we're looking forward to having you next time to finish up the talk.
Well, good. Again, if you guys have any other feedback, you can even be a not anonymous negative, non-anonymous negative, but seriously, constructive feedback. If you have it for Dr. Good or for Dr. Summers or me, let me know, because I do want to not just talk and feel good about talking, but actually do something useful. So just provide feedback.
This was highly, highly requested. So
good. I hope it lives up to that then.
Definitely. All right. Thank you so much.
Y'all